But then I discovered that the most beautiful faces in my practice, they are the high angle cases or high angle cases. And imagine if you already, you will wait till the age of 16, so most of the growth will be done. So what you do will be stable if you control the tongue and the lips and the nasal breathing. So the most beautiful faces in my practice, they are the high angle cases. And the last video that you have seen with me, this is a marketing video that I did in my practice for gum smile cases. So the marketing material in my practice, they are among open bite cases, high angle cases, facial asymmetry cases. And some of them they have even skeletal class 3 base. So yes, you can deal with the challenging glass occlusion. And the maxilla, you can impact the maxilla. You can do differential impaction. You can do impaction for the posterior part of the maxilla. You can impact the whole maxilla, and the mandible will follow. So you will support the midface, and you will support or you will express the jawline and the chin. So let's take one of the challenging dimensions, okay? The high angle cases with gummy smile. Then after gummy smile, we'll cover the open bite. And finally, we'll cover facial asymmetries. Then we'll take the question and answer section. The first thing to do with gummy smile cases is differential diagnosis. They are not the same. Sometimes it's the upper lip, sometimes it's the clinical crown lip, sometimes it's the premaxilla, sometimes it's the whole maxilla. So this is one of the most important slides in our master class. So these are the 4 common etiological factors behind gummy smile. In some cases, you have short upper lip or hyperactive upper lip. So it's not the teeth length, it's not the smile, it's not the face. Other cases, no, you have short clinical crowns or lingually tilted crowns like a class 2. So you need to deal with the teeth. But other cases, no, you need to deal with the teeth with the bone. So the upper incisors with their bone, they are extruded. They have ventral extrusion. And the case that I like, the true gummy smile. Vertical maxillary excess, where the lower facial third is longer than the middle third. So in such cases, I'm going to do impaction for the whole maxilla. So let's have some fun and to have case, one case for each one of these. And imagine always that this is your case next morning. For example, this is Thea. She's 12 years old. I'll do my best to delay her treatment till the age of 16, but she's not happy about her smile, and her parents, they insisted to do braces. And for me, if you do examination for her, the etiology behind the gummy smile in her case was both short upper lip and short clinical crown. So she had delayed basset eruption, but she has healthy gums. And as you know, till the age of 16, you will still have apical migration of the gum, and with age you have drop of the upper lip. So this is not permanent. So you need to anticipate age and time while you are doing examination and diagnosis for gum smile cases. For the intraoral photos, everything was accepted. You can read that crowding, and she has class on the right side. So it was not that difficult treatment. But her parents, they refused to do IPR. So if you have crowded lower incisors, even if you put the right toe, they will reply. You need to apply IGR with the rectifying tool. So I go in their case. I'm not going to focus on torque selection and mechanics. And I visioned her case in 1 year. She came to my practice with Gummy Smile, and she lived the practice with Gummy Smile. So for some of us, this is nothing, but this is a big change. You see that in the smile of the graph. And this is a right vertical view. Plus one now. For the upper arch, we have some development. For the lower arch, because they refuse the IVR on the bottom teeth, will end with the proclination of lower incisors. So already, this is her skeletal pattern. She has mild diameter proclination, and she had crowding. And because we didn't do IVR, this is her lateral stap at the end of the teeth. So what do you see about the upper incisors? Are they less proclined or more proclined now? Less or more? More proclined. Keep this in your mind. Okay? And this is her lips for the teeth. She has short upper lips, she has concomitant lips. And you agree with me. With the teeth, what happens for the upper incisors? Now they are proclined. So what will happen for the upper and lower lips? Are they going to close or open? Of course, they should open. But I gave her special training. Let's see using the upper lip. So this is her in the middle of the teeth, and this is her with the end, at the end of the teeth. Always remember the lateral stap. So soft tissue is more important than the hard tissue. So you need to treat or to train your patients how to do the right lip seal, the good habits. This will mask the proclination. So what do you not like in terms of lateral stap? Maybe it's good lip support for her while she is aging. So you need to do training for the muscle. This is 1. 2, she entered the practice with Gummy Smile. She's in the middle of the teeth, in the malleable position, and this is her final smile of the graph. Are you happy about our final outcome? Are you happy about the final outcome? Yes or no? No. No. Because still she has Gummy Smile. She came to me with Gummy Smile. She lived the practice with Gummy Smile. And the parents, they were not happy. Doctor, you did nothing for the Gummy Smile. But you need to have the answer. But finally, there is big difference between the start, initial Gummy Smile and the final Gummy Smile. What do you think is the difference? Forget about the arch width. It's not important. Beauty has 2 components. Beauty has 2 components. Number 1, symmetry. Number 2, proportion. In life. Forget about the components. Beauty has 2 components. Beauty say that this is beautiful. It has to have 2 components. Symmetry and proportion. So she entered the practice with L-level asymmetrical Gummy Smile. She left the practice with symmetrical level Gummy Smile. So 50% of the beauty is there. The missing 50% is the proportion. And age will deal with that 50%. So this is her smile at the end of the treatment, and I should expect apical migration of the gum, drop of the upper lip, so I will leave the other 50% of the correction to age. I ask the parents, please don't touch that gum. If you are a dentist and Tia visited you, most of the dentists, they will have that feeling of irritation. I need to do something. that smile, and they are going to do some sort of gum or gingivectomy, which is wrong. Still, she is, you can say, 14 years old, and don't do soft tissue contouring before the age of 16, because I expect apical migration. And this is what we have done. Nothing done except the vein. So this is Tia at the start of the treatment. This is Tia at the end of the treatment with different gum smile. We restore the symmetry, but we don't have the proportion. And this is here at the age of 14, and we get till the age of 16. And this is Tia at the age of 16. I did nothing, just observation, even whitening, nothing. So that change in her smile from here to here because of normal thing, apical migration of the gum. So don't touch the gum before the age of 16. So the thing that they didn't like, the parents, made her a model later on, really model, because we tried to call the parents, I want to see Tia as recall visits. So they answered me that, we are, as parents, we are not able to have Tia to home. She's busy, even she's at school. She's busy doing a new job. She's working as a model. So the thing that we didn't like at the start made her a celebrity. And nowadays I have patients, please, we need the same smile like Tia. So sometimes as orthodontists, you need to keep your hands away from the problem. If the age will do that. Yeah. That's why my message in such cases, don't impact. Are you going to put tags? The lower pressure tag is normal, so don't impact in growing patients, and don't rush for soft tissue contouring, laser soft tissue contouring in growing patients. You need to wait till the age of 16. So this is my recommendation for the first surgical practice. If you have short iliacal tracts. If you have hyperactive upper lip, again, it will drop down with age. And showing part of the gum is anti-aging. So keep that very small. It's anti-aging phenomenon. So this is for the first two surgical practice. What about the other extrusion? In such cases, the upper incisors, they will continue with the extrusion with their bone and gum because they don't have incisor stone. And most of these cases, by the way, they had ortho treatment before. So the ortho treatment, they didn't finish with stable interincisal angle. For example, this is our colleague. She's dentist, Eva. She has extruded upper anterior segment. You can see the extrusion in her lateral side. And these things will continue with extrusion. She did ortho treatment before, and they did extraction for the upper anterior premolars. So you have two options, hospital or non-surgical treatment. And of course, non-surgical treatment. Don't cut the bone of the maxilla. You need it for the beauty of the face. These are the intraoral photos for Heba. And what I have done, I bonded her case. I did impaction for the maxilla, but before that we need to extract wisdom teeth. And her age is the good age for the patient, so we extracted the age. And this is the case at the bonding session. And this is the same case after 10 months of treatment. So imagine this is your colleague, and she's your patient, and you spend 10 months of the treatment, but still she is very small. And she's not happy. That's why the most important thing is to tell these patients, the ones that have gummy that don't expect too much change in the beginning of the treatment. They will not see big change in the 50%, the first 50% of the duration of the treatment. they will start seeing that later on, once you start the interaction. So I did the revision and I added mainly 2,000 theory to inclusion for the anterior part of the maxilla. Once I did that, she asked me to remove the braces because she got engaged. And she's planning to have her honeymoon without the braces. So I removed the brackets. She had her wedding with the honeymoon, then she came back. I wanted her teeth back, and we continued the treatment, and this is the final outcome. So she came to me as desperate dentist. She's happy. She got married. She had the first child. All of that because of the treated very smart. So very smart cases, if you treat them, it's a life exchanging, sort of changing experience. So this is her lateral side, before and after. So if you follow the upper incisor, the incisor show at rest almost it's 9 millimeters. Now it's normal. So if you follow the movie, especially the upper incisor, you'll see the amount of invasion. So it was a true change on her face. She now can eat the lips or bring the lips together. Before, almost she's showing the full length of the incisor. Now she can keep the lips together, and she's happy. So all of that just by adding 2 tabs, or maybe in some cases 4 tabs. In this case, we use 4 tabs. In most of your cases, we use only 2 tabs, distant to upper canal. And that interaction will be enough to restore the beauty of their face. And again, you see the support of the new face. Even if you go back without smiling, you start seeing cheekbone. So maxillary excess is a must, because in such cases, that bone will be translated from the teeth to the cheeks. The fourth activation factor is vertical maxillary excess, in which you have 2 vertical maxillary excess, and you need to do the fourth one surgery. But for example, this is Hani. The lower facial curve is almost half of her face. And this is not a true smile, this is a formal smile. So the true smile, she has almost 6 millimeters of gross smile. So 6 millimeters of gross smile, maybe this is too much, but again, this is within our limits. So this is the physical factor behind her case. And one of the options is before surgery. This is invasive procedure, and this is irreversible damage. We will not do surgery. I'm not doing surgery for any open bite or any gummy smile. All of them, they are treated. But the problem that she is in class 1. Her bite is perfect. So it's not the teeth, it's the bone. But I need your imagination. If I am back in class 1, what will be the occlusion with the treatment? She's in class 1. But if you're back in class 1, what will be her occlusion later on? Class 1, or class 2, or class 3? Class 3. Because you will have auto rotation. So you need to prepare the toe for class 3 in such cases. And again, you need to extract wisdom teeth. To extract the wisdom teeth. And I want hair case using insignia, but if I'm going to go on hair case using Damon Ultima, this should be the tool. So we picked Borgan tool for the lowers, because she is in class 1 and will have all rotation of the mandible while you are doing the invasion. So she will end with edge to edge bar. But for the upper arch, we take critical current torque because we are thinking about what are the unwanted forces with impaction. What will happen with impaction? Flaring or propionation. So I need to prevent the propionation. That's why this should be the torque. She was in rush, so we started the impaction with 4 tabs at once. And we did the impaction. Then I did substitute contouring. And she was so happy. For the right focal side, this is the day of impaction. But I need for you to think about the mechanics. That ball chain from that tab to 6 to 9 will do retraction and impaction. And if you look at the position of the tab, they are so high. They are just below the line we call it. Because we have membrane excess. Big amount of bone. So I need that range of force. And I need the lower arch to follow. That's why this will be my mechanism. Impaction and retraction, and what do you call this? What do you call that elastic? Triangle. But is it anterior or posterior? Posterior triangle, classically elastic. So if you want to have the lower arch following the upper arch while you are doing retraction and impaction, you need that elastic. And we finished hair case again in class 1. And if you look at the canine will have mesial defect. So I did composite it up. So you need to restore the normal shape of your canine. The canine is the pin. You need to have it in the right shape. And I did surface contouring to create the wedge effect. For the upper arch, nothing special. We prevented the flaring. But if you do impaction, don't bone fix it here. Because while you are doing the impaction, teeth and bone will move, but the gum, they will not move. They need more time for remodeling. So most of the gum on the palatal side is hyperlazy. So this is not the final clinical crown length from the palatal side. And to have resolution there, you need 3 months. So after 3 months, we did bonding for upper fixed finger. So always remember, the soft tissue remodeling will take more time than the bone remodeling. This is the amount of impaction. This is a movie. So if you follow the movie, you see the amount of traction of the maxilla and the auto-rotation of the mandible. But what's missing in hair profile is this. What do you call that shape? Flat shape. So the most beautiful shapes, they are the well-developed bony shape. I used to tell my patients after finishing their treatment, if you are not happy about your chin, we can think about chin job. We can do some sort of procedures for the chin to enhance the profile, but she was happy. This is hair true smile. So we are talking about 6 millimeters of gummy smile. And this is hair smile at the end of the teething. So if you ask me what are the limits, you can do impaction with 4 millimeters, you can do soft tissue contouring for 2 millimeters minimum. So you can deal with any of 6 to 8 millimeters of gummy smile without surgery. And the good thing that if you impact the maxilla, the whole soft tissue will be changed. So I need from all of you to follow the lower lip while we are doing the impaction. So what you are doing will change the whole face. Some of you will ask me about the risks of such procedures. But always remember to compare these risks to the 4-month surgery. So What are the risks if you are doing impaction? Of course, if you are applying too much force, you will have absorption. Maybe you'll have necrosis if you have history of trauma. And you will have gingivitis, especially the bilateral side. You may end with some bone exostosis, and as we have said, you may have flaring for the molars and the incisors, but again, you can control all of them, all of that between your hands. So apply very low force level. You can do soft tissue contouring for gingival swelling after 1 or 3 months of reposing. And you can prevent the flaring of molars and other incisors if you give the retroclantor. But again, compare that with what? With the fourth one. For example, this is one of my old cases. Very, very old, maybe 20 years ago. And she was referred from a surgeon. She has almost the same gummy, and he decided that he needs a surgeon to do orthodontic surgery. So this is her case at the start of the treatment, just before the surgery, and this is her case after the surgery. You compare that with infection. The surgeon will cut the bone and they will through the bone. So you will lose bone. So this is aging. And always, you will not be happy about the face aesthetics at the end of the treatment. You still not finished with that photograph. This is aging. So please, don't do report one surgery for lupus. Let's have another case. You remember Joanna? Again, she is having gummy smile, and she has a little pressure curve. And the upper and lower incisors, they are profound, by the way. Upper and lower incisors, they are crowded and profound. So imagine if you impact, they will propline more, but ultimately will come to you, will help you, and will give you retrocline. And she asked me to finish her treatment in 1 year, because she wants to have her wedding without the response. These are the intraoral photos for Joanna, and you can see with me the apical proclination, lower crowding and proclination, upper crowding and proclination. We extracted the wisdom teeth, and we wanted her case. If I was to change anything, these should be retroclantor, and I changed them during the treatment. So we started with initial wear, 14. Now we are in the flexible wears. Once we reach the sessile wears, I started with the anterior segment to do the impaction. And in all of my cases, you see that I'm using flip Kimberly hooks. This is more hygienic, and this will give you more range of force. Then I added my posterior tabs for retraction and retraction. Still we are doing the retraction and retraction. I did the replacement of the toe. They were neutral, so I changed them to be a retrocline toe to prevent any flaring. I did another repositioning for the upper lip central. The good thing with impaction is everything is reversible. So while you are doing the impaction, you have the chance to take smiling photographs. And smiling photographs, they are free. Not like the surgery. The surgery is only one procedure, one chance, and in most of the cases, this is too much. But with orthodontic impaction, I will continue doing smiling photographs. That smiling photograph before the impaction, and this is her smiling photograph while we are doing the impaction. So I feel that, yeah, I can do more impaction. So keep taking smiling photographs while you are doing the impaction to make it gradual, till you are happy. If you are the patient, you are happy, you can do the one, or you can stop the impaction. Let's go back for Nana, and we finish her case. When we were happy, we controlled the upper incisors without flaring, we did superficial contouring, and we did whitening later on for her case. And she was ready for the wedding without the smile. So, still flexible way. Then I started with the anterior tabs. My favorable position for the upper tabs, I set the upper canines, and for the received tag between tweet number 6 and 7. So that function from that tag till tube 6 till day9 will take the whole buffer segment up and distant. So refraction and invaction. We don't have A's now. Then in the next visit, I will extend my ball chain till the credit hook. So I'm moving the buffer segment first, then I'm going to the anterior segment and I do a refraction or sit back. So I'll keep doing that the whole treatment. And if you see, I'm not using any elastic. This is the day of repositioning. That canine was neutral tone, not color. Again, refraction and action. Now she's using +1. That occlusion will settle. And now we'll talk about the fourth training. I'll give her showing exercise. So after the morning, if they are mobile, so I will ask her to chew gum 2 hours per day in order to settle the occlusion. Nothing special on the left side. Again, also chewing exercise on the left side. On the lower arch, we added tongue tailors during the treatment. But remember, we started with proclination. So you need to control the proclination. So if you check the overjective graph, the controlling is increasing with time because the torque is separation with the IBR. So the upper and lower incisors, even we did impaction, they had a crowding. You compare them with the pre-treatment or the during the pre-treatment. No, we reduced the proclination. All of that because of the power of the retrocline torque with the IBR. And this is her lateral staff. She has proclined upper and lower incisors with crowding, and we reduced that amount of proclination. She has good lip support, and she has very strong chin, and that strong chin with that normal nose needs some lip support. So I will not do too much retraction in her case. And all of that was reflected on the profile. You see that she's a model. All of that without Botox, no fillers, no surgery, just normal Borgan. And I'm sure you can see with me the cheekbone below her eyes. All of that because of the impaction. And you can see the jawline now and the chin projection. So in all of my gummy smile cases, if you black the maxilla, you will support the midface. And you will have all the projection of the mandibule, so you have the jawline and the chin projection. So 2 parts of the attractive face, they are done in one malocclusion. And of course, I will take care of the smile. So the 3 components of any attractive face, there will be in the gummy smile cases. Even if you check the frontal view, you see the bone around the eyes. This is bone change. It's not fillers. All of that was natural. So I like excess of the maxilla because that excess of the bone will help you to support the midface. And you can see with me the jawline now. And for the smile, you remember, this is her true smile. So we are talking about 5 to 6 millimeters of gummy smile. And this is her final smile identification. It was wide, symmetrical smile without any proclination. So the most beautiful faces in my practice, they are the gummy smile cases, in which we consider them as challenging attitude. But if you use the, let's say, variable tones, this will help you to control your aesthetics. And by the way, this is a good material for marketing. So you can market your practice as non-surgical treatment for gummy smile cases. And I think here in Vietnam we have some sort of gummy smile cases. In our region, they are 20%. So 20% of girls in my region, they have gum smile. So imagine 20% of the girls who are working now in Vietnam, they have gum smile, and they are not doing anything because they have been told that the only treatment is surgery, or maybe Botox for the upper lip, or cutting, or doing gingivitis. You can market your practice as non-surgical correction for gum smile. So this is for the gum smile. You can do differential diagnosis. You can do designing the treatment depending on the etiology. Of course, I prefer to delay the treatment until the age of 16. So let's speak a summary about the patterns of elastics that we have seen with me for the last maybe 2 days. So what do you call that elastic? Triangular clustering. You need it in bypass cases, you need it in gum smile cases. And the other pattern of elastics is anterior triangular clustering elastic. You need it in clustering cases. The other pattern of elastic is in the class 2 cases. For example, in the class 2 with open bite, you need something I call it anterior triangular cluster to settle the bite and to keep the anterior correction, because that patient she has increased overhead. On the other hand, in the other class 2, that patient has facial asymmetry. So I needed to do differential in action. So while I'm keeping the class 2 correction, that patient has a cluster. So in order to keep the cluster correction and at the same time to settle the occlusion, I will need a serial triangular cluster. And to control the tongue, you need 10 femurs. So what's the right position for the 10 femurs? For the upper arch, I'll put the margin. Just touching the gum. And on the lower arch, they should be more inside. So we know now how to control the tongue, where to put the 10 femurs, how to design our elastics. So if you know now how to put your 10 femurs, you can deal with the next malocclusion. Otherwise, but at first, I like this title, maxilla dominans. Focus on the maxilla, mandibule is up below. Again, should we treat any open bite? Let's say that you have a child at the age of 9 with open bite. Are you going to put risk? Let's say 12, 16. So you need to make management for your way of dealing with the cases. So it depends on the etiology. For example, if you have a two-tank trust, you need to deal with the tongue. If you have tongue-sucking habit, you need to deal with the habit. 3, it's better to keep periods of observation because in most of the cases, the open bite will reduce with facial maturation. And I don't want to close the open bite, then the growth will affect my treatment or the facial symmetry will end with canopy. So it's better to delay the treatment till the age of 16. And the other reason, you need to extract this. So we know now etiology. So what's the etiology behind open bite cases? In some cases, it's skeletal. I mean, it's not in the soft tissue, it's in the bone. And we have two scenarios. We have post-maxillary, maxillary excess, or it's not the maxilla, it is the mandible. You have downward rotation of the lower arch. By the way, we have clinical cases to understand that etiology. Number two, maybe the soft tissue, mainly the tongue, so you need tongue flavors. Number three, maybe habits, like tongue-sucking habit, and you can control that. In very rare cases, you may have ankylosis or primary failure of eruption. But in these cases, it is a single tooth, or in the primary failure of eruption, mainly it's related to posterior bite, not anterior bite. So for the habits, if you have a case like Anad, he has anterior bite, he has tongue-sucking habit, and they travel 6 hours by car, and they want me to do diagnosis and planning and execution same session. So I added, we did the right diagnosis, he has tongue-sucking habit. I added tongue fingers in the upper arch, not for the tongue, for the tongue. And within 2 months, this is the patient at the day of consultation, and this is him after 2 months. So it was effective because we stopped the habit in the right time. And all of that will affect his bite and his face. So you can see with me that he has now lip seal nasal breathing. So you need to control the habit. Or maybe you have atypical swallowing in the soft tissue, I mean the tongue, like Nadal. He has anterior bite, reverse smile arch, upper lower spacing. So I was not sure that should I add that or not. But we extracted the wisdom teeth. Then I tried using only the tongue fingers to see the response. So we restored the normal overbite and just by controlling the tongue position by using the tongue fingers. This is the same patient after debonding, it was stable result. And you can see the amount of change during the treatment and then the treatment. At that time, I treated him using insignia, so this is removed before the treatment. But it is the same if you are going to use Damon Ultima. In his case, you are going to pick Procline chalk because he has spacing to prevent lingual tipping. And this is the movie for the upper and lower incisors where we are correcting the upper bite without the need of tabs. So you put the tongue fingers, then you'll see and wait. This is the correction of the smile arc. We created smile arc. In his case, is this a stable result or not stable result? It depends on you. So you need to train your patient after removing the tongue femur or during the tongue femur period how to do conscious swallowing exercise. So this is the same patient usually. So if you focus on the training how to swallow, this will be a stable result. Another soft tissue like Dua. Again, she was about to lose her lower incisors because of the anterior tongue crest. And you will see that, by the way, in a lot of patients. So even if she had ortho treatment with fixed retainer, but she has atypical swallowing, you have two scenarios. If she broke the fixed retainer, we are lucky, because the tongue thrust will push the crowns. But if the same patient has anterior tongue thrust and the fixed retainer was intact, the tongue will push the roots. So she was lucky, she broke the fixed retainer. So if you have any old ortho case and the fixed retainer is stable, not broken, and you have the roots coming outside the bone or gum recession, this is because of tongue thrust, not the fixed retainer. So you need to fix the swallowing and always expect hidden tongue thrust. That's why always keep the tongue cables ready for any case. And put that in the fifth plan. Write down plus minus tongue cable if needed. You will start that in the lower arch, maybe on the other arch. Then you will pull that with the training. So this is what we have done with that patient. We added tongue cables on the lower incisors, mainly lower left central and lateral. And I need to support the bone. That's why I picked the provider. So we removed the old fixed retainer, we did descaling, this is the legal bonding. We used the provider. You can see the black triangles between head teeth now. But if you combine the provider with IPR, you are going to improve the bone and the gum support around the lower incisors. No way to do that without using vesical variation or the propine tool. So if you have any period case in your practice, even if you have single gum recession on one incisor, you need to pick propine tool. Because that propine tool will reinsert the root inside healthy bone. So this was a hair case and it was effective treatment to control the habit and in the soft tissue, which was the etiology behind the open bite. And continue training your patient how to do normal swallowing. So imagine this is her panoramic X-ray at the start of the treatment. You see the amount of distortion of the lower anterior segment. And this is her panoramic X-ray at the end of the treatment. So yes, the proplantor will give you the right position of your teeth. Now she has healthy bone support. She was like this. So we are moving the teeth with the bone, not within it. Because we are applying very low force leverage. Don't put too much force. And she couldn't bite with her front teeth. Now she is having normal bite, overbite, and overject. With conscious swallowing exercise training and new lateral fat. Now she has normal interincisal angle with normal tongue position. And you can see that in the movie. And if you follow the facial features, now they are balanced. So some patients, they will like the tongue cameras. Doctor, can you keep them? Because they make something good for my face. I had a lot of stories in which patients, they asked me to keep the tongue cameras. So we are reviewing the etiology. So we covered habits, soft tissue, mainly the tongue. What about the skeletal pattern? This is so important. So I need from all of you to focus with me, please. Okay? This is one of the open bite cases. Adult patient. And this is another open bite case. Intraoral, you think that they are the same. Almost they will give you the same clinical picture. But if you check the lateral staff for the first skeletal pattern, compare that with the second one. Are they the same? Are you going to put the same tool, the same task, the same mechanic? So the first one, the problem is in the maxilla or in the mandible. What do you think? The first one. This one. Is it the maxilla or the mandible? What's the problem? The maxilla. So she has what I call the maxilla excess. So that excess in the maxilla is the etiology behind her skeletal upper body. So what I need to do, I need to extract it and I need to do differential inversion. I need to see what is the maxilla. On the other hand, for the other one, it's not the maxilla. It is the mandible. So the mandibular angle is rotated downward. So I need to have anti-clockwise rotation of her mandible. So in the first scenario, the rotation of the occlusal fin will be passive because you are doing work on the maxilla and the mandible will have passive rotation. On the other one, no, you need to have active rotation. You will hold the mandible and you will pull it up to have that rotation. Let's start with the first one. We'll treat both of them, by the way, and you'll see the difference between the two scenarios. This is Ola. She's a dental student. And she did orthopedic before, and you can see the traces of her old fixation. And her teachers in the dental college, they convinced her that, Ola, your case is the surgical one. No way to be treated with orthopedic. Don't waste your time. Don't waste your money. You will need surgery. She came to me as second opinion. Do you think I'm going to do surgery? She has reversed my arm. But now you are smart people. So let's do the right diagnosis. I call it aesthetic-oriented diagnosis. We'll start with the face, then the smile. What is to evaluate in the face? The most important thing is what? Symmetry. Do you think she has symmetrical face or asymmetrical face? Symmetrical or asymmetrical? Asymmetrical, not symmetrical. Which side is bigger? Maggie, which side is bigger? The right or the left? Okay. It's not easy to know. But she has the asymmetrical face and it's the left side. Apply the same measurement. I mean, take the middle of the forehead, put your line, then follow the face perimeter till the middle of the chin. Do the same on the right side. Which line will be longer? The left. Yeah. Do you think she knows that? Or that? No? No. And always the tongue, remember this, always the tongue will mask the malocclusion. For me, the definition of such malocclusion, the true Ola, she has gabisman with candy. But the tongue come forward and made that curve in the smile. That's why you don't see the gummy smile. So always open bite cases, they are hidden gummy smile cases, and most of the cases you have candy. So I told her, I want to look. At the beginning, you will not like what I'm doing, because I want to create smile art. I want to create positive smile art. So she will develop gummy smile, and only she has asymmetry. So you will see the canting later on. And of course, we'll start with the teeth. So in terms of the face, she has asymmetrical face right, sorry, the left is bigger. She will end with canting, and I'm going to create positive smile art that will create gummy smile. She has anterior bite. The other bite is half centimeter. But don't forget, her old orthodontist did occlusal adjustment for 7. So he removed almost 1 millimeter. Imagine if I add that 1 millimeter to 7, how many we are going to open anteriorly? 2.5. So her true open bite Should we extract that tooth? Don't extract the maxilla. Even if you have Borgan teeth, keep that tooth. Even you can keep the root if you are sure you need extraction. Keep it because you need the roots to do Borgan. Then after finishing the case, you can extract that Borgan tooth and you can put implant. Don't extract, even if you don't like the prognosis of the teeth. Keep them. You need the roots for Borgan. And you see her tongue. She has very strong tongue. That's why I needed 4 tongue fillers in her case. What to do for the wisdom teeth? Extraction. So extract the wisdom teeth. And I want to create a wedge effect in her smile. So I want to create a smile. So this was the start of the treatment. Again, she was treated by a signal. But if you want to treat her using Damon Ultimate, what will be the torque for the upper teeth? Yes. What will be the torque for upper teeth? You are going to do induction. So it should be a retroclavicular torque. And she's in class 2. So what will be the torque for lower incisors? Retroclavicular. So she will have upper and lower retroclavicular. So if this is your case, you need upper and lower retroclavicular. I will manage to create positive smile arc. So we are creating positive smile arc, more positive smile arc. Now I need to evaluate the smile. So this is her smile at the start of the treatment. We are creating positive smile arc. We are creating more of her positive smile arc. So this is the true Ula. This is true Ula. You see now the asymmetry. So the asymmetry now is obvious on the left side. You see the canopy. Of course. But again, she's busy. She has high marks, by the way. She is so busy with studying and she's not taking care of her oral hygiene. So imagine that every morning she is entering the dental college in front of her teachers who told her that you will need surgery, and this is her smile. They told her, Ola, we told you that you are wasting time with budget. You will come back to us and we'll do surgery. So, of course, we'll not do surgery. And now it's time to evaluate the triangle of symmetry. So I want to make everything inside that triangle to be in symmetry and in proportion. So I need to do differential induction on the left side, more. So we added our anterior pads, and we are doing the posterior induction, and on the anterior side, I'm doing more induction on the left side. I'm guiding here including in class 1, and we finish in class 1. By doing the posterior induction and more on the left side with the anterior pad. This is her right upper view. You see her tongue. We added 4 tongue tenors, 2 lowers, 2 uppers. And I keep training her how to do conscious oral exercise. I'm guiding her manually to fit in class 1. Then we added the anterior tongue tenors, more induction on the left. We are guiding her right using anterior triangle class 2. I will leave her without too much elastics for at least 1 follow-up visit to make sure that she has a stable bite. Then we did debonding. So now she is in a beautiful class 1 region. For the upper arch, I needed tongue tenors to be ginger. We kept the upper lip 6. And because I didn't use Damon tubes, I had the flaring. But if you are using Damon tubes, you will not have the flaring. So this is the amount of flaring. So I need to add another 2 tabs. These tabs will control the flaring. We are now in the finishing stage, and we finish hair case without using the upper lip 6. We did into retreatment, and that lip is healthy now. For the lower arch, nothing special. In most of your cases, the lower arch is beautiful. So we need to add pen flavors to control the pen position and function. So this is all out before and after. Before and after. If you don't like the arch shape in the lower arch, this is because of TMA wires. I don't like TMA wires. They are expensive, don't buy them. They will not give you the right arch development for the upper arch, and they will not withstand the abnormal pen position in the lower arch. So the best finishing wires for me, they are the sensitive wires. And for the upper jet, we corrected that in class 2. You remember, she's in class 2. But the issue behind the class 2 was vertical problem, not anti-posterior one. And for the lateral staff, you like the occlusion. What about the bone? Are we going to get skeletal change now? So this is her lateral staff at the end of the treatment. So yes, it was skeletal change. So we did impaction for the posterior part of the maxilla. So we had auto rotation of the mandible, and we extracted those in teeth. This is very important movie. Would you please follow the posterior part of the maxilla? So it was true intrusion, and the mandible will be a filler. That's why I like to call it maxillodontine. One of the things that I did for Ola is a training. You see this hyperactive intense muscle. So we kept doing training for Ola to have relaxed lip C. She's improving. And for the smile, you remember the sequence. But because we created with a smile arc, then we did the impaction, this is her final smile. It's not a surprise to tell you that I hired Ola as part of my team in my practice. And now she is doing her degree in pediatric dentistry. So she is covering pediatric patients. And just last week, she asked us to have a vacation. Vacation for what? For her engagement. She got engaged. So this is Ola before, and this is the same case after 18 months of debonding. So the most important thing is the positive smile arc. So in posterior maxillary excess, you need to impact the posterior part of the maxilla. Most of your overbite cases, they will develop gum smile, so you need to deal with the gum smile, with the anterior occlusion, and in some cases, like Ola, you have facial symmetry, so you need to do the fresh impaction. The most training that I'm using with Ola is conscious swallowing exercise. Conscious swallowing exercise. So this is the first scenario. What about the second scenario? In which the mandible is the etiology. So in the young case, the dominant rotated mandible is the reason or the etiology behind the open bite. And the posterior height of the maxilla is normal. I don't need to impact the posterior part of the maxilla. I need to rotate the mandible. Again, she has been told that your case is surgical. So when I told her that I can't treat you without surgery, she didn't believe me. So she left the practice for 2 years, then she came back, okay, I feel I'm desperate, please treat me without surgery. So this is what I need to do with Diane. I want to rotate the lower arch like this. These are the intraoral photos for Diane. Again, she has a strong tongue and teeth and bilateral spine. This is her vernacular X-ray. Most of my patients, they are retreated. And this is good, by the way. If you are good with Damon Ultima, you will have a lot of referrals. Because most of the patients, they are having challenging malocclusion and they don't want to go for surgery. So you will have the reputation that you can treat them without surgery. We extract the wisdom teeth, and this is the day of bonding. And again, I put the hair case using insignia. But if this is your case, what will be the Damon Ultima torch selection? Like Ola, retrocline, because you want to prevent proclination while you are doing inaction, and you want to prevent proclination lower incisor because she is having disease of her jaw. She has anterior bite. I will ask her to do conscious swallowing exercise. So the amount of bite is decreasing. Then I added my tongue femurs. You can see the traces of the tongue femurs. And now she is in ischial bite. That's why I needed bilateral plastic elastics to protect the cross bite and to create positive over gel. And I will add 2 tabs now, just to have control on the upper posterior part of the maxilla, not to intrude the maxilla, to get encouragement from these tabs for my class C elastics. And this is my technique to rotate the mandibule. I will add deep grammar on lower sevens in the fasciole. They will be high deep grammars, while I'm applying vertical elastics. So vertical elastics anteriorly, high deep grammars on the posterior part of the maxilla. But in order to prevent extrusion of your anterior part of the maxilla, I will add tabs. So the tabs here will prevent any extrusion of their smile, and I'm using heavy vertical elastics with posterior bilateral. We are now in the finishing stage, and I was happy about the upper arch in terms of smile, but that lower arch, I feel that it has discanting. So what I did, I added deep grammar on the lower right foot, and I added elastics only on the left side to have that rotation. And we are done. And I did some shape contouring. Let's see that from the right perspective. I added my deep grammar on lower sevens. I asked them to do conscious swallowing exercise. All of that will do true intrusion for the posterior part of the maxilla. I'm applying bilateral class 3 elastics to widen the maxilla and to create positive overjet. I added tabs to have anchorage for the class 3 elastics. Now I added my deep grammars on lower sevens. anterior triangle class 3. Then I want to hold the premaxilla using my tabs while I'm applying 316 heavy elastics on the anterior segment while I'm keeping my deep grammar. So I need your imagination. You are applying vertical elastics anteriorly and you are doing bond of rotation or momentum on the anterior segment of the lower arch. And you are in the sensory wires. So all of that will twist the occlusal plane. This is what will happen. I gave her conscious swallowing exercise, showing exercise, and she is doing so great. This is the summary for pair case. We started with downward rotated occlusal plane. With the braces, nothing is happening. Then at this stage, I added the steel deep grammar on lower sentence, I1, and I started my vertical anterior elastics. So this is what will happen. So we have anterior upward rotation of our lower mandibular angle. All of that will push her chin. All of that will push her chin more forward to show the jawline and the chin projection. So again, this is Leanne before and after. So do you see the amount of rotation of the occlusal plane? The occlusal plane was like this. So what we have done, we added degrammers at 7 while we are in the sensory wires, and I added vertical anterior elastics, and I took my anchorage from upper anterior tab. So this was happening. So it was anti-clockwise rotation of her occlusal plane. It's not posterior abduction, it is anti-clockwise rotation of her mandibular angle. And this is the change in her profile with time. So we gave her a chin. And she came with obviously convex profile. Now she is having normal, slightly convex profile. So what we have done intraorally affected her face aesthetics. So this is there before and after. So you can see the chin. She is so happy because we avoided surgery, and you can see we have she has now normal facial features. You can see the jawline. Her face was tapered one. Now it's normal one with jawline. And when I started the teeth in her tongue was posturing forward. Even you can shake your hand with the tongue. So always the tongue is posturing forward. And you see that she has psychological problem because of the tongue position. But this is her smile and then the teeth. She's now happy. She was laughing in all the visits. And she traveled to Germany to complete her university education. And while I was doing the correction of the olive line, she had a canopy on the right side. If you check her face, so if you remember, the force in the upper anterior tab on the right side was more than the left side, so we corrected the canopy. I'm not sure about the schedule, but is this the right timing for the coffee break, the final